dignity was broken or fractured, as we called it. Well, you can see these people were in more psychological distress. They had lost their will to live. They expressed a desire to die, and they had more problems with psychological issues like depression and feeling hopeless and loss of sense of meaning and purpose. Physically, they were also more troubled. They had more pain, more difficulties with bowel-related issues, and even their physical appearance was problematic for them. This is something that in my writings I've called the intimate dependencies of care. And again, even though some of you heard me talk about this yesterday, it's worth repeating. These intimate dependencies are of profound importance in the work that we do. When you think about it, though, I mean, most of you work in hospitals or in healthcare settings, and the idea that a patient would need help with bathing or dressing or toileting, these are very intimate aspects of care. But it's so common, this happens everywhere, that we as healthcare providers stop to actually even notice it or see it. We see this as being routine. And if I was to be talking now about compassion, what I would be saying to each of you is, for a moment in time, you need to imagine yourself requiring assistance with bathing, dressing, or toileting, or someone that you love. When you personalize it in that way, of course, these are the kinds of things that turn someone's world upside down. Oftentimes, I'm sure many of you have heard someone say, if ever I reach a stage in my life where I need help with these intimate dependencies, life wouldn't be worth living. And yet, as I say, we pay very little attention to how these things are done, who does them, how they take place. And certainly in our data, we found these are things that can assault a dying patient's, or any patient, I would suggest to you, sense of dignity. Quality of life, of course, was worse for patients with a lack of sense of dignity. And then finally, what we did when we looked at all of this data together is we said, is there a way of, if we had one thing that we could predict that might influence loss of sense of dignity, what would that be? And we looked at all of our data, and we did some special analysis and statistical analysis, and what we found is that the issue of appearance, or how people think others see them, was the single most predictive variable when it came to understanding sense of dignity. Now, how do we understand that? How we believe others see us, how we perceive ourselves to be seen. And again, for those of you who are at the workshop, this I think is the last story that you'll hear me tell that I told yesterday, but it's an important one. Years ago, I was working at Memorial Sloan Kettering Cancer Center, and this is a very large American cancer hospital. And I was looking after a young man who had a primary brain tumor. He was very near end of life. He was wasting away, really looked like the skeletal remains of the young man that he had once been. And one morning when I walked into his room, on his bedside table, either he, perhaps when he was well enough to do so, or a family member had placed a photograph of him when he was in a perfect state of health. And he had been a bodybuilder. So he was striking this kind of incredible sort of Adonis-like pose. And I remember looking at this incredible contrast, this young, robust, healthy, strong man, and this young man who was now dying and really, if not moments, days away from death. Years later, when I was looking at our data and trying to understand this issue of appearance, why is it that appearance and how we think we are seen by others came out as the most predictive variable in sense of dignity, his story came back to me. In a flash, I thought of him. I thought of that morning. I thought of the contrast between him lying in his bed and that photograph. And the message that came to my mind was, this is how I need to be seen. This is how I need you to see me. Now, it's not that patients want us to pretend that they're not sick or that they're not wasted away or they don't have some horrible lesion or disfigurement as a result of their illness. That would be a lie. That would be untrue. But what they do want us to see is that they continue to be a person, a human being. If we stop seeing the person and only see the illness, people begin to feel that they have vanished, that they have disappeared. It's a great irony, and that is we spend all of our professional lives learning how to look after patients, and yet the one thing we discover as we proceed in this work is no one wants to be a patient. At least no one wants to be seen exclusively as a patient. And everyone here in this room has experienced this. You go for health care, you go to see a physician, and for that moment in time, you are that lump. You are that blood problem, that abnormal value. And when you look in the eye of your health care provider, if the only reflection you see is one where you see your illness, you feel that you as a person have disappeared. Now, we continued to do this work in Dignity, and we actually introduced what I have called a notion that I've titled Dignity Conserving Care. Care that allows us to approach health care in a way that will conserve, that will save dignity for patients. And we describe this as a new model for palliative care. What did this model look like? What did we discover, and what is this model based on? And again, for those of you who attended the workshop, you will recognize this particular model because this model is the foundation of much of the work that we've continued to do for many, many years. This model is based on information from dying patients. So this is not a Chochinov model. I have not died, not even once. That was a funny line, wasn't it? Even though I look this bad, the truth is I have not died, not even once. But patients near the end of life have shared with me their experiences. And the model that emerges from that investigation says there are things that the illness can do that can influence sense of dignity. Now, some of these things look very typical of palliative care. In other words, symptom distress, physical distress. You might be saying, these things are very traditional in palliative care. There's nothing special about this model. There's nothing different about this model. Because people continue to say that the thing that matters at the end of life is treat my pain, keep my symptoms as low as possible. But if we look at other things on this dignity model, we begin to notice that there are a variety of other concerns that patients tell us about. Besides general psychological distress, medical uncertainty, death anxiety, not knowing how death may come, what the future may hold, how it may look. One of the projects in Canada that I chair is a project called the Canadian Virtual Hospice. That's virtualhospice.ca. I encourage you all to go there and to visit it. There is free information. It's available to everyone at no charge, and information that you can share with patients and families and volunteers. We have over 1,000 Canadians, closer to 1,200 every single day from across the country coming online for information. The most frequently downloaded article from the Canadian Virtual Hospice is an article called When Death Draws Near, a description for patients and families who want to know, what can I expect? So again, you can see that that adds validity to what the model is telling us. We also found out that there are things socially in one's environment that can influence sense of dignity. Do we respect privacy? Do we provide appropriate support? Care tenor. This is the tone of care. I was presenting this once to a group of nurses in oncology, and one of the nurses says, "Oh, I've always thought of that as the fragrance of care." You know, like a perfume, the fragrance, which I thought is a lovely phrase. What does the tone of care mean? It means that patients can tell, just based on the way you are, the way you behave, the tiny subtleties or nuances, as to whether or not you appreciate them as a human being, whether or not you as a healthcare provider are acting in a way that recognizes personhood. It's an important variable, because what it means is that we always think of, in palliative care, doing the right thing with the patient or saying the right thing with the patient or with the family. The data that we have says that how you think about your patient, what goes on between our ears, has a profound influence on patient satisfaction. So when I've talked to healthcare administrators, hospital presidents, what they tell me is the reason that they get complaints, the reason, and in fact there have been studies that have shown the reason that you as a professional might eventually be sued or be called in front of your regulatory body is not because you made a medical mistake. Those things happen, they're tragic, but they're rare. The reason most people run into trouble is they get the tone wrong. They don't pay attention to the human aspects of communication, and that's where people get hurt and where people get angry. As one of my dear colleagues in Canada tells me, and he's the head of a palliative care unit, he says that patients and families will forgive you almost anything, but they won't forgive you lack of kindness. Now, in the middle of the model, we see something that we call the dignity-conserving repertoire. Fancy words, what do they mean? It just means that we all come to palliative care or end of life with a lived experience. We all have relationships, we all have beliefs, we all have outlooks, we all have a spiritual life or a religious life, and those aspects of who we are affect the way we deal with and encounter end of life. And most of the things in here are about, do we continue to feel a sense of who we are, a sense of self, a sense of preserving roles that were important? Generativity, legacy, do we feel that our life has made a difference? Do we feel that after we are gone, the world will be, at least in a small way, somewhat better or somewhat altered because of the fact that we were here? Did we make a difference while we were here? Again, I know I'm going through these things quickly because we have so little time. All of the information about all of these studies can be found online. They're all published. You can go to PubMed, or we have a website that we call dignityInCare.ca. And we try and keep all of our articles there and announcements about workshops and training opportunities that we try and make available. Now, we also pursued dignity, let me just see here. We also pursued dignity along many pathways following the foundation of the model. So in some ways, you can think of this model as a map. Where does the map take you to? And how can we use this map in order to inform healthcare providers? Now, one of the things that we've discovered, as I've already said, is that what goes on between our ears, how we think about our patients, matter. So what can we do in our own head to remind ourselves of the importance of our attitude and behavior, the way we are in this world? How can we remind ourselves that our attitudes towards patients make a difference. So I decided to write an article that was published in the British Medical Journal a number of years ago, and I called this the ABCD of dignity-conserving care. Now, this idea actually isn't so original. It borrows from the idea that in internal medicine, we have the ABCs of critical care. And the ABCs are something that every physician should know about. So God forbid if Dr. Barboza started to choke to death, and I ran over to him and I held his hand, I looked deep in his eyes as he took his last breath, and I gave him professional empathy. You would say, my God, you're a physician. Why aren't you making sure you've cleared his airway and breathing is normal and circulation? And I said, well, I'm a psychiatrist. I am giving him professional psychiatric care. I'm holding his hand. I'm looking in his eyes. I'm asking if this experience of choking reminds him of his mother. I'm doing what I was taught to do as he takes his last breath. You would say, that's completely crazy. Just because you're a psychiatrist, you must know the ABCs of critical care. But when it comes to the humanities of care, we say there are no standards. What do we say to students? We say, be a good person. Try your best. Trust in English, the expression is trust your gut. Just do what you think is right, be a good person, and get on with it. Well, the truth is, not everybody has a talented gut. Not everybody knows how to do this kind of humane care. And so this is where I thought, well, why can't we create some core competencies that everyone in medicine has to know? This idea that somebody is an excellent technician. They're terrible with patients. They have lousy bedside manner. They're not particularly kind, but they're very good technicians. I say, well, the automobile industry needs people who are good technicians. Cars don't have feelings. People do. And so why can't we introduce core competencies in the humanities of care that everybody is responsible for? So let me tell you about these core competencies. And they're nothing fancy, but if we could do them and practice them, perhaps medicine would be a friendlier place. A stands for attitude. And whose attitude? We're talking about your attitude. Your attitude makes a profound difference on patients' sense of dignity. Now, when I say these things, I'm always worried that people are going to say, oh, he's a psychiatrist. He's trained to say these things that are very, touchy-feely is the expression we use in English. So what I say is, look, this is not about me being a psychiatrist, and this isn't just me saying this is the right thing. This is data-driven. We all live in an age of evidence-based medicine. The data says that your attitude makes a huge difference, in fact, the biggest difference to patients when it comes to sense of dignity. Let me tell you about another study that proves it. In this study, we looked at over 200 dying patients, again, all in palliative care, less than 6 months to live, primarily end-stage cancer, and we said, which of these items would you connect to sense of dignity? Thinking how life might end? Only about 41% said, yes, that would influence my sense of dignity. Not being able to accept things, maybe about 71%. No longer feeling like who you were. 75% of people said, if I no longer felt like the person I was, that would influence my sense of dignity. Now, this is a very important existential question in palliative care. It's probably not one you've asked patients very often. Do you still feel like you? But when you think about illness and the psychology of illness, the psychology of illness is the psychology of loss. illness takes away. When we're just a little bit ill, it takes away time, it takes away convenience. When we're very ill, it starts to take away function. When we're profoundly ill, it starts to take away the thing that's most sacred, and that is things that we identify with core self. So at some point in time, illness can become so threatening, illness can take away and cause so much loss that we may feel that what's in jeopardy is self, that I no longer feel the person I was. And even though we don't ask it very routinely, 75% of this cohort of dying patients said, that's something that I would connect with my sense of dignity. If we look at the very top, feeling a burden to others, in other words, serving no sense of purpose, and therefore not being treated with respect or feeling worthy of respect. Why is this connected to attitude? Because respect is something that comes from the outside. You and I can offer respect, or we can withhold respect. The truth is, every single time you walk into a room with a patient, the patient is looking at you for something. And that's something, and I apologize if it's a complicated English word, affirmation. Can you affirm your patient? To affirm means, can you show them something about in your attitude that says, you, the patient, matter? And so it's not only Harvey Chochinov who says, your attitude needs to be one that appreciates patience. My opinion matters not at all. The data says if you don't respect your patients, if you can't demonstrate that respect, that is the issue that is most likely to be affiliated with sense of dignity. Well, this becomes a very important and even deeper matter then, because you have to begin to say, well, how would I feel in this patient's situation? If we're going to really get a handle in our attitude, what's leading me to these sorts of conclusions? Maybe I'm making some assumptions here. Have I checked those assumptions? Is my attitude, does it have something to do with this patient? Or perhaps it has something to do with me. Is there something about my own psychology or the way that I am wired and made up, or my own experiences, that is causing me to feel great difficulty? I remember years ago being called to a ward, and one of the nurses was saying that there was a dying young woman who was very difficult, and she was just having a very difficult time dealing with this woman, coping with this woman. What became obviously very quickly is that when I began to interview this dying woman, she was lovely, she was young, she had 2 children, she had a young husband. And isn't it interesting that the nurse who wrote the consult also happened to be young and have 2 children and a young husband, and looking in the eye of her patient made her feel profoundly and overwhelmingly vulnerable. So we have to understand what is moving us to have our specific reaction to this patient. And the truth is that oftentimes we're trained to believe what we see. We walk into the room and we see a clinical situation and we say to ourselves, we get it. We understand what's going on. And if you look at this photograph, of course, initially you look and you say, okay, I understand what's going on. But if you stand either to one side of the frame or the other side of the frame, the picture changes entirely. And so the message, as clinicians, we have to be very careful of what we assume and how we put things together when we walk in that room. We may assume that someone is suffering. We may assume that we understand the source of their suffering. It was a few weeks ago I walked into a room in our palliative care unit, and there was a dying woman. She was in her late 60s, certainly looked the picture of somebody who was dying with a certain amount of existential angst. And I assumed, I knew what was going on, that it must be difficult to be relatively young, in your 60s, and now dying of cancer. And so I began to explore what that was like. That was my assumption. Very quickly, what she told me and corrected was the fact that I've led a good life. I'm not struggling particularly with the fact that I'm nearing end of life, but if you want to understand my angst, you need to know that my 40-year-old son is in a hospital on the other side of the city dying of pancreatic cancer. My angst is about his coming death, not about my own. And it's one of those instances where you shake your head and say, oh my God, if I didn't stop to check what was really happening, I would be entirely in the dark. And if I didn't stop to check, I would walk out of that room still thinking I knew why this person was in angst, and I would still be wrong and in the dark. B is for behavior. So if our attitude is now one that acknowledges personhood, what are some of the behaviors that we can show in a very simple way that let the patients know we acknowledge personhood? Do we stand at a bedside? Do we sit in a chair? Do we meet someone's gaze, or do we try and avoid their gaze? Even something as simple as asking permission to do a physical exam, it gives the message that this is your body, and whatever happens here, you are in charge. Finally, do we use the excuse that we no longer have a form of cure to rationalize no longer having contact with the patient? How many people remember being a young trainee and going on rounds, and the very last person that's seen on rounds is the person who's least likely to be cured? This oftentimes happens on busy medical and busy surgical wards, and yet we know that communication and connection is a powerful intervention. If we can have contact with people, especially people for whom we don't have cure, we can do a great deal to lessen suffering by showing people, by taking the time to do what this young man is doing, that despite the fact that we can't cure, we can still care, and caring makes a profound difference. Now, C is for compassion. Compassion is usually the most challenging one in terms of teaching, because people say, can you really teach this idea of having a deep awareness of another's suffering coupled with a wish to relieve it? And people try many, many different things to show how you can encourage compassion. We can have people read literature about death and dying. We can read philosophy. We can read poetry. We can understand ethics. What I say to you is each of you are very different people, and the way you each are going to reach compassion is going to be different based on who you are. Some of you come into it in a very natural way. Some of you may come into it through life experience, being a parent, having a child, looking after an ill parent, maybe being close to nature, maybe reading philosophy or history. We all come to it in different ways, and I think if there's a common denominator, I would say the denominator is this: we all need to do something, if we're going to feel compassion, that puts us in touch with our own vulnerability. If you don't think of yourself as vulnerable, if you don't understand that you, like your patient, are on a life course that is uncertain, a life course that begins with birth and will end with death, with all of the uncertainties in between, it's almost impossible to feel compassion. So whatever you do that can put you in touch with your own vulnerability is likely to put you in touch with your capacity to feel compassion. Now, I've been reading a great deal of history lately because in some ways, I think reading history allows us, or allows me, to connect with people in a compassionate way. If we learn the details of a historical moment, it also connects us to something in a way that is unforgettable. Think about your patients. When you connect with something very intimate, something very personal about them, that usually is the fact that remains with you for years afterwards. We forget the blood work, we forget the pathology, but we remember the story, we remember the anecdote. So let me use this as a metaphor in some ways of how we can connect with our patients. Because when we look at this photograph, in some ways it's like any other black and white photograph. This is a photograph of a middle-aged man, black and white, indistinguishable from any other photograph you've seen. If I didn't tell you any details of this photograph, I would assume you would forget this man and this picture by the time you go off to coffee break. Let me tell you a very short story, a detail, and I would suggest to you that after this story, you might remember this photograph the rest of your life. This is a picture of William Osler. William Osler is the founder of modern medicine. He wrote the first major textbook on modern medicine. One day, Osler was in his office, he was Sir William Osler, he had been knighted. He was in his office, and one of his colleagues was knocking on the door to go visit him. His colleague suddenly heard some coughing and choking, and it sounded like the story of Dr. Barboza. It sounded like William Osler was choking to death. Now, this colleague wasn't a psychiatrist, so he didn't run in to hold his hand and ask him if this reminded him of his mother. He ran into the room. He wanted to rescue Sir William. What did he discover? William Osler was in his study trying to force a nasogastric tube down his nose and down his throat. His colleague was astounded. He said, "Sir William, what are you doing? What's going on? Why are you doing this?" I won't imitate what William Osler sounded like when he responded, because it would make me sound very silly. But what William Osler said is this. He said, "We place many of these tubes down patients. I thought I ought to know what it feels like." William Osler then offered his colleague a nasogastric tube to try it. His colleague said, "No, thank you," left, and that's the end of the story. So why is it an important story? First off, because it gives you a detail that now allows you to remember this photograph in a way that creates an indelible memory. And we can do that with patients. If we recognize personhood, if we recognize some aspect of who they are, it makes them people. It gives them a story. Why else is the story important? William Osler is one of the greatest men, one of the greatest figures in modern medicine. And his message, although he was very much a pathologist and a physiologist, his message was, there are human experiences in medicine that are important to understand. You know, there's some things we may not be able to measure, and some things we might not be able to see with our own eyes, but needing to know what it feels like to be a patient, William Osler was saying, is of profound importance. And the last thing, of course, is that because it comes from William Osler, it makes the source of this information undismissible. So if I, as a psychiatrist, simply was saying to you, look, everyone out there, you need to understand your patients, you might say, well, you're the psychiatrist. They pay you to understand patients. We all have very busy lives. You do it. I'm going to get on with being a surgeon. This would be fair enough. But when the founder of our profession says, this is something you should listen to, it adds credibility to that message. Now, the D is for dialogue, and of course, the D is the last letter in my mantra, so we're coming close to the end of my talk, not quite. I will take probably another 5 minutes or so that we end almost on time. Well, maybe I should go over by a half hour. It's the Spanish way, right? Then it would feel very much the Spanish way. But I won't. I'm still very much Canadian. Maybe Canadians, when it comes to time, are far more rigid than Spaniards, but so be it. I will try and end fairly close to being on time. So the D is for dialogue, and dialogue means that we have conversations. We talk with patients. Can we have conversations that acknowledge personhood? Now, at this point, usually people in the audience begin to think or say, oh my God, you want us to talk to patients about who they are as people. We are very busy clinicians. We stay in our clinics from morning till night. I will have to sleep at the hospital if I start talking to my patients. It'll take forever. And what I say is, it's not about putting patients on a couch and doing psychotherapy. Sometimes it's a tiny, subtle word or two. This must be difficult. This must come as a shock. I'm sorry to have to tell you this, or this isn't the way I'd hoped things would go. It's a tiny, tiny few words that can give the message, I understand, you are a person. You may be embodying an illness, but you are a person. In that article that I told you about in the BMJ, we had a question that we've ended up calling it the Patient Dignity Question, or PDQ. And the PDQ reads as follows: what should I know about you as a person to help me take the best care of you that I can? And I would suggest to you, it doesn't matter if you're in palliative care or if you're in obstetrics care or anywhere in between, can you think of an instance where the response to that question wouldn't inform the work that you do? What do I need to know about you as a person to take the best care of you that I can? We're currently conducting a study, believe it or not, on that question. How do you conduct such a study? What does the study look like? Well, we're going into the room of patients in palliative care. We ask them if they would partake in our study, and we'd like to have a brief conversation. By brief, I mean 5 minutes, sometimes 7 minutes, but that's as long as it is. The conversation is framed by this question: what do I need to know about you as a person to take the best care of you that I can? We're not asking for your deepest, darkest secret, because that's not something you may want everyone to know. But if the way healthcare providers see patients influences how patients feel, this question is meant to change the way healthcare providers might see you. So if you came into hospital, imagine, what would you want your healthcare provider to know about you as a person, as a human being, so they could take the best care of you that they could? We've had amazing answers. Some of them very straightforward, like, you need to know I'm deaf in my left ear, so you'll have to talk on my other side. We had one woman who was very religious and told us what she needed you to know is she was afraid to die alone. And she'd hoped at the moment of her death, in case she was alone, she had a fantasy that her hand would be in the hand of God and she wouldn't feel so alone. We had a patient who told us that she was very afraid because she was modest, that when she could no longer keep her body covered, that somehow this would be sacrificed. And we told her that we will make sure her modesty is protected. We have this conversation. We go and summarize it into a paragraph or two. We come back for 3 reasons. We read it, we check to make sure we got it right, and finally, we ask the patient, do you want this on your medical chart? We've done this with nearly 70 patients and families. So far, I think about 68 of the 70 have all said, yes, that is information I would want on my chart. That is something that everyone who comes in this room should know about me. This is a summary from one patient. This is a woman who is First Nations Aboriginal, and she suffered from the great tragedy of the residential school system, where Aboriginal people were taken out of their homes and put into schools in a way in which they lost their language and lost their culture. Here's what she said, and this is a 5-minute conversation. Mrs. F says that because of the residential school, she always had a hard time trusting people. She in fact moved 82 times so as not to let anyone get too close to her. Well, this has gotten better over time. She still struggles with being able to trust people. She wants to, but it's hard for her. She sometimes worries that she won't be told the whole truth, or that people will see her as not being deserving of the whole truth. She appreciates people being friendly towards her, but she's frightened of authority figures. I remember she told me, white coats scare her. Authority scares me, but I'm not as bad as I used to be. Now, I can imagine someone trying to take care of this woman and not knowing this information. But doing that would be like me trying to walk from here to the back of this room with a blindfold. Is it possible? Yes. Is it dangerous? Yes. Might I get hurt? Yes. Would it be effective? Absolutely not. So the information we can find out, when you find out about personhood, it can make the difference between knowing a person versus simply dealing with a patient. And in the last moment, we have used our model of dignity to develop an end-of-life intervention that we call dignity therapy. Again, it's another way, a psychotherapeutic way, in a very short fashion, of trying to understand people and their story in a way that we record their story, we transcribe their story, and we return their story to them in a document that they can then give and share with family members and pass along for generations to come and to be able to appreciate who that person was. We've published a number of papers on this. We've published phase 1 trials. We've published phase 3 trials. And the results have been that patients and families have said, this is helpful. This enhances my sense of dignity. It gives me a sense of meaning and purpose, and it even changes the way my family sees or appreciates me. Even families, 6 to 9 months after the death of a patient, say, dignity therapy helped my now deceased loved one. In fact, 65% of family members said, this helped my deceased loved one as much as anything else that took place during a course of their dying. More recently, we've done randomized control trials and shown that dignity therapy actually enhances end-of-life experience. It can improve quality of life, enhance sense of dignity, improve spiritual well-being. And so we've done training for dignity therapy in many places. Last night I felt very proud to add this to the slide. We had a full-day workshop, and I thought Spain should now be on the list of places where dignity therapy training has taken place. But there are trials that are taking place now around the world and papers that are coming out showing how this brief intervention, an intervention about personhood, can change sense of dignity. And so with that, I'd like to close by saying we tend to sometimes associate the word dignity with political issues. When people oftentimes speak of dignity, they're speaking of a political movement that has to do with the right to die, the right to hasten death. Yet the word dignity has been in the language from the time of Hippocrates. The word dignity has been a core value of medicine since the time of Hippocrates. I hope that the work that I've shown you in some ways makes you comfortable with reclaiming the language of dignity, showing you that looking after patients with dignity opens up a whole variety of ways for you to be a better care provider and to acknowledge your patients as persons. Thank you all very much.